It's the weekend. Be good to yourself. It's Katz's Corner with Dr. Aaron Katz and Dr. Philippa Cheatham, where you can get simple, straightforward answers to your questions about health, from diet and supplements to lifestyle changes. To reach Dr. Katz and Dr. Cheatham, call 800-848-WABC. Now, live on 77 WABC, the chairman of urology at Winthrop University Hospital in New York, with co-host Philippa Cheatham, attending in urology at Winthrop University Hospital. Here is Dr. Aaron Katz.
Good morning, everyone. Welcome again to another live round of Katz's Corner here on WABC Radio in New York. Wake up. Tune us in. 1-800-848-WABC. That's right. We're live. Dr. Cheats is away training more haifu down in the Bahamas somewhere, but we are live. 1-800-848-9222. Thanks, Cash. Wow, great intro. And my special guest this morning, he's been here on Katz's Corner. His name is Dr. Jonathan Haas. He's going to come on in just a moment. He is the chief of the Division of Radiation Oncology and runs the most famous treatment, I think, in the area for prostate cancer, the CyberKnife. I want to remind everyone we are running the Men's Health Seminar. It's filling up rather quickly this year. I'm very pleased about that. It will be again at the beautiful Garden City Hotel on Father's Day weekend. I know my parents are going to come there. You'll get to meet Dr. Cheatham and myself, as well as many, many men who share the same vision, maybe the same clinical condition that you may have, and you can learn so much on that day and meet and greet so many wonderful people. And that will be at the Garden City Hotel. Very easy to register. You can just go to menshealthseminar.com. That's right, menshealthseminar.com, and please register and sign up today. Dr. John Haas is here. He runs the Division of Radiation Oncology. Good morning, Johnny. How are you?
Good morning, Aaron. Thanks again for having me on.
Okay, great. I'm not so sure that is his microphone on, Cash? Because I didn't hear him that well. Try again, John.
Can you hear me now?
I certainly can.
Well, good morning, and thanks again for having me on today.
Okay, great. You have your breast cancer, so take a hike T-shirt on, which you've given me one, which is I guess it was a run that they did at Winthrop.
Yeah, Winthrop had at Jones Beach State Park last year. Winthrop had an event, or it was a big event. Winthrop took part in it, where we had a walk to support breast cancer for Breast Cancer Month in, I believe it was October. And it was a really nice event. Several hundred people turned out.
That's wonderful. Yeah, and I know, something I didn't know about the treatment that you've been using for prostate cancer, CyberKnife. And if you want to learn more about CyberKnife and Dr. Haas, it's very easy. You just go to winthrop.org. You treat breast cancer as well with this.
We do. We have a protocol that's open. It's been open for several years. So the way that we've historically treated breast cancer after a lumpectomy or taking out the breast cancer tumor is with 6 weeks of radiation. And it's very, very effective. It has an 85% success rate as far as keeping the breast cancer away. But similar to the program that we started years ago for prostate cancer, where we narrowed it down from 9 weeks down to 5 days, we look to do the same thing with breast cancer. So we've now treated approximately 20 patients, and instead of having 6 weeks of daily back and forth radiation, analogous to what we do with prostate cancer, now we have a 5-day radiation program, and the women have really done fantastic. It's great.
And, with PSA and, prostate cancer, we can monitor the patients by their PSA. And by the way, the patients that I've seen over the last year and 3 months that I've been at Winthrop have just done very well in terms of their quality of life.
Can I tell my story?
And their PSA response. But what story is that?
So Aaron and I, Dr. Katz and I, have a mutual patient, and it's a young, vibrant guy in his 50s. And Aaron, answer this question. Other than obviously the most important thing, which is being cured of your prostate cancer, with our vibrant younger men, what's the big issue with them?
Well, their big concern is sex, and then there's sex, and then there's the sex.
Right. The top 5 things after cure is sex, sex,
especially
sex.
A younger guy. I mean, 50s and 60s,
right.
I guess. Or
so I saw 70s, a gentleman who I love, in his mid-50s, early 50s, really vibrant, dynamic guy. You sent him to me. He had intermediate risk prostate cancer, which means a Gleason score 7, and saw me about 6 months out, really just doing fantastic. And he kind of looks at me sheepishly in the follow-up room. He goes, "Doc, I have to ask you a question." And I'm like, "Sure." He goes, so my wife and I were having relations, and the next morning she noticed that some of the private hair was coming out a little bit, and she asked, "Is it possible that the power of the CyberKnife is rubbing off on me?" So I looked at him, and I started hysterically laughing. The two of us, the patient and I, were laughing for about 5 minutes. But my point being is that these people are doing so well that they're back to their full life as far as potency and relations, and it's really nice to see not only they're doing well from a cancer point of view, which is the most important thing, but also their quality of life is great.
Yeah, I mean, you look at the quality of life of these guys. You're absolutely right. We're going to get back to breast cancer in a moment because it is an interesting topic and something that I wasn't aware that CyberKnife can treat not only breast, but I guess you treat lung cancer and some brain tumors there as well.
Right. So CyberKnife was invented by a neurosurgeon, John Adler, who's a great guy. He's at Stanford, and I know him pretty well actually now throughout the years. And CyberKnife was designed to compete with something called the Gamma Knife, which was a fixed radiation treatment where the neurosurgeon actually had to put screws into the head to keep the head still during radiation. And John Adler was kind of visionary in that. He said, well, why don't we just take the same type of robots that we use to put, say, cars together or things like that, and put a linear accelerator or radiation machine on it. So it was started initially for brain tumors, to compete with the Gamma Knife. So we use it for things like trigeminal neuralgia, which is a condition where patients are just in chronic pain from the fifth cranial nerve, which innervates the face, just misfiring like a faulty circuit. So we can actually target that first part of the nerve, which we call the reentry zone, and essentially shut it off. We use it for things like acoustic neuromas, which are benign tumors of the nerve that innervates hearing, where you have a little teardrop-sized tumor, and we can kind of ablate or kind of knock that down. So the utility of this, I mean, we've kind of, prostate cancer is our bread and butter because it is so effective, but we use it for many, many other things.
What about pancreatic cancer?
So we use it for pancreas. Pancreas. I mean, that's an awful disease. Pancreatic patients in general really don't do well, and it's disappointing to us because what happens is we'll treat them for 6 weeks of radiation, and a year or two later, unfortunately, more often than not, the cancer comes back. So with CyberKnife for pancreatic cancer, we can do the same treatment in 1 to 3 days. So we're doing equivalent with CyberKnife as we are with the 6 weeks, with the advantage that I'd rather those patients that don't have a great life expectancy be home with their family as opposed to with me.
Yeah, well, what you're doing is phenomenal, John. Really, out at Winthrop, and I know that you've expanded the program beyond prostate cancer, which is fantastic because the quality of life of these patients to go through, 9 weeks of radiation versus just 5 days, and I guess. So for breast cancer as well, it's just 5 days?
It's a 5-day treatment. It's not for every breast cancer patient. Your lymph nodes have to be negative. The margins, meaning where the surgeon cuts, has to be negative. But again, the women in 5 days are doing as well as the women over 6 weeks. And again, they get back to their life. I mean, my job is twofold. Number one, to cure the patients of their cancer. And number two, to get them back to their regular life so this can just be an afterthought or a memory.
Let me ask you, if the nodes are negative and the margins are negative, why do they need any treatment? Why do they need radiation at all?
Great question. So in the 1970s and 80s, there were a series of 7 randomized trials looking at women with breast cancer, and the largest is from this country, from a group called the NSABP. And they looked at 1,800 women with early-stage breast cancer, and they broke them up into 3 groups. One group had a mastectomy, one group had a lumpectomy and no further therapy, and the third group had a lumpectomy followed by radiation. And with the data now out really beyond 30 years, patients that had the mastectomy, the breast off, and patients that had the lumpectomy followed by radiation did the same. Chance of the cancer coming back was 15%. Patients that had the lumpectomy and no further therapy, to answer your question, that number was 40%, which is unacceptably high. So that's the reason why in those patients that want to keep their breast, which is obviously most women, we recommend or mandate radiation afterwards.
Yeah, well, that's interesting. So you can't always rely, I guess, even for prostate cancer, although the patients that have prostate cancer and they have their prostates removed, the ones that are margin negative and lymph node negative, there's still a chance that it could come back. Patients say to me all the time, I thought, I had my prostate removed. How could it come back? I don't understand that. And there are studies that show that, it's about 10, 15%, maybe not as high with the breast, but still there are a significant number of men. And so, people ask, well, should they have radiation after prostatectomy? And I know that you've done that, although the CyberKnife at Winthrop, wouldn't be applicable to those men.
Right, we do the
but
conventional.
You have the other radiation there that you do.
Right, that's the question we both get asked. I had a prostatectomy by a very good surgeon, and everything was out. My PSA went to 0. And why is it slowly creeping up? And if there's even one cell left behind in the prostatic fossa, or where the prostate used to be, 1 becomes 2, 2 becomes 4, 4 becomes 8, and then you have a detectable PSA. More often than not, when we restage these patients, CAT scan, bone scan, you don't see anything, so you have to assume that there's some cells in the prostate bed, and we irradiate that.
Yeah, that's the scary thing about cancer. These stem cells, I guess, if you want to call them that, even if there is that one left behind, that it could start to multiply. And some of the tests that we have, are, like the PSA is not super sensitive to detect that. You could still have a 0 PSA and there could still be that stem cell. And then over time, I've seen plenty of patients, I'm sure you have too, where PSA was 0 for a while and then a year or two later, it pops up. And that's why we tell patients, no matter if you have CyberKnife or if you have surgery or if you have cryosurgery by me, that you still need to be monitored, don't you? You still need to have that PSA every 3 or 4 months.
Without a doubt. I see my patients at least out to 5 years. And, more often than not, these guys do great. And 80% of the time, 90% it's a social visit. How are you? How's your PSA?
Yeah.
How are your relations?
Yeah.
But, there's, as much as I love my patients, which I do, it's not a social visit. It's that if there is a problem, you catch it early and you intervene early when you need to.
Let's go to the phone lines. We're talking this morning with Dr. Jonathan Haas. Again, he's the Chief of Radiation Oncology, runs the CyberKnife program at Winthrop. That's winthrop.org. If you have a phone call, it's 1-800-848-9222. Let's go to Bob in Franklin Square. Good morning, sir. How are you?
Yeah, good morning. Good morning. I had surgery at Sloan in September of 11. I had a Gleason of 6, and I decided to have the prostate removed. I have a family member that works at Sloan, and I spoke to a number of doctors, and Dr. Easton, I had it removed. My problem is just what you're talking about, the quality of life. They said the nerve endings, apparently they rated them. They said they were very good after the surgery, but I'm having a problem with ED. I went for some instructions on the shots, but I'm just not doing that. I'm taking the Cialis, Annual Viagra, and really no results. I was wondering, how long can you go like that before the muscle is dead, that you will never again get an erection?
Well, it's not really the muscle, Bob. It's the nerve endings, frankly. And, we used to tell patients, wait a year. Okay, now you're out over a year, right? I mean, it was 2000.
I'm over a year.
Yeah, you're over a year. We used to tell patients, you wait a year. But then a lot of the studies have shown that you really need to intervene earlier. With the medications, and you've tried the medications, but why didn't you try the injections? I guess the awkwardness of it. I don't know. In fact, when I went there for the instructions, the 15 milligrams they started with didn't really work. I would have to take more, 20. Yeah. Well, most guys, John, Bob, when you speak to them and they say, oh, you're going to have to put a needle in the penis, they're like, whoa, I'm not doing that, And, of course, there's a lot of diabetics. About 50% actually of diabetics are or do have troubles with erections, and they're more, just comfortable with self-injecting themselves into the skin, so it's not a big reach, I guess, to go down into the penis. But for yourself, you've never done that before. It maybe seems uncomfortable. I think there is a doctor that we have out in Garden City. His name is Dr. Brett Mellinger. I know you're in Franklin Square, but Brett Mellinger does this on a routine basis. He's an excellent doctor. I would probably see him because it really comes down to how you're taught and how you're approached by the doctor. You need a caring doctor who's going to sit there and really show you how to do it. And that can help you because at this point, I'll be frank with you, I don't think the medicines are going to help you anymore. And I think you need something. And if you're not comfortable with that, then Bob, you may want to consider an implant. And I know Dr. Mellinger does those at Winthrop. It's an inflatable, implant that goes into the penis. You don't see it on the outside. It looks and feels like a normal erection. And that's probably if you really want to fix the problem, so to speak, that's probably would be my recommendation, Bob.
Right now, Dr. Mellinger, how do you spell his last name, please?
M as in Mary, Ellinger. You can also check him on the website at winthrop.org. He's on the website, and he gives a lot of lectures. In fact, as with Dr. Haas, he'll be giving a lecture at our Men's Health Seminar. I hope to see you there in Garden City. But, Bob, I think that's what I would do for you. Okay? Is your PSA okay?
Yes, it's been very good since I had it removed. The incontinence in the beginning was tough, but after like 2 months, that was fine. You know?
All right. Well, thanks, Bob. I hope that helps you. You know, and we're speaking again with Dr. Jonathan Haas this morning, who runs the Division of Radiation Oncology at CyberKnife, the CyberKnife program at Winthrop. You know, John, I just was thinking about, and if you'd like to give us a call, by the way, it's 1-800-848-9222. You know, with prostate cancer, John, you know, we talk about the trifecta. We talk about guys that have had the treatment, that have a 0 PSA or a stable PSA, let's say, you know, normal erections and normal urinary function. If you look at the surgical experience in my, you know, and I take care of, I don't know how many patients over the last 20 years, and I also look at the publications, that number of men that reach the trifecta, that get all 3, is way low.
Yeah, lower than you would think.
Way low. I mean, it's probably around, you know, 20 or 30%,
right.
You know. Now, you know, we have some terrific robotic surgeons at Winthrop that I think do better than those numbers, because I've seen those numbers and they do great. You know, Dave Gershbaum and Joe Jamal, terrific guys. But how do you think you do? You know, do you think that you do pretty well with that trifecta of hitting that number?
Yeah, we look at that. I mean, it's not 100%. I wish it was.
No, it can't be 100%.
If you look at our potency, you know, the rate, the one that's lower than the others. So our cure rates are in the high 90%. Your cure rates by PSA, which is the most accurate way to follow prostate cancer. And you and I have published on this and presented this specifically for CyberKnife. Urinary issues, you know, we have our peak urinary issues about 2 to 3 weeks after the radiation's finished. The urinary frequency, the mild discomfort. That I always bring my patients back for their first follow-up at 3 to 4 weeks, and I do that because the first week after treatment, the side effects peak, meaning the urinary frequency, the rectal urgency. Second week, they level off. Third week, they start to get better rather than worse. As far as potency, you know, we're looking at about a 20 to 25% impotency rate. So that's the one that knocks us down a little bit as far as the trifecta. But, you know, if I have a treatment that's 95% effective by PSA as far as cure, that's 95% effective as far as getting you back to your baseline for urine, and 75% for potency, you know, that's still better than a lot of the treatments that are out there.
Do you think that, like this last caller, if you start on the medications like the Cialis and the Viagra very early on, maybe even before the CyberKnife, and then immediately after, you think that helps?
Yeah. There was a paper that was published at ASTRO, which is our national meeting, where they looked at starting patients, you know, exactly that with Viagra during treatment, and those patients seemed to have a better instance of maintaining their potency. I have one guy in particular, another young, vibrant guy, is a martial arts instructor. You know, he and his wife have a very, you know, healthy, you know, sex life. And he said, is there anything that I can do to just really maximize so that I have everything going forward? And this is right after I'd gotten back from Boston for Astro, and I just heard the presentation on that paper. So I started him on it. You know, and he's doing great, and he's doing great sexually. Would he have continued to do great sexually if I hadn't put him on it? You know, probably. But this was the guy that I used as my test case, and he's doing great. Yeah,
I mean, and that's what you have to do. I mean, you have so much experience, and I know that you are, you know, an international training site for CyberKnife, and you've been doing. How long have you been doing this now?
So we started in 2005.
Okay.
We've treated over 1,000 patients for prostate cancer in particular. So yeah,
is that the most of any center, any CyberKnife center?
I believe it is. You know, I think, you know, it's certainly the most in America. I think there's a center in China, believe it or not, that does more than we do.
Yeah.
But we are one of the international training centers, so we have teams from all over the world that come to spend time with us. You know, we've had teams from you know, Ohio, Michigan. I'm laughing because we had a team about 4 months ago that came from the Ukraine. And you know, they came straight from JFK Airport, and all they wanted to do when they got out of the taxi was smoke. You know, these guys came out. It was like a Marx Brothers movie. They fell out of the taxi cab and they're smoking cigarettes. And I guess, you know, in this country 30, 40 years ago, all the doctors smoked. I guess, you know, in Eastern Europe, it's still kind of the same thing. But it's kind of flattering that people are flying all over the world to be trained by us. People are flying all over the world to be, you know, treated by us. You know, and there's other centers that are out there. I don't pretend, you know, to be the best on the planet, but there's value in experience.
Yeah, but you know what you have? You have a team there too. It's not just you as the director. You have a team of physicists. You have a team of nurses. That really make sure that the proper dose is done, that the patients get on and off the table, that they know where to show up. You make it just a very nice experience for a cancer patient that's about to undergo treatment. That is so important.
Well, I think it starts, and you can attest this now, having been with us for a year and knowing me for several years, it starts with the hospital culture. The hospital, John Collins, Gary Schwal, the hospital in particular, has kind of taken the approach that it's a very integrative, team-oriented hospital, where really anything you need within reason is there for you. If you ask for something and you have good justification for it, as far as the team, as far as the support, as far as the environment, as far as the culture, it's the entire aggregate of doctors, physicists, nurses, physicians, administration, your waiting room, everything. It's just a nice place, a nurturing place to be treated.
Yeah, and I see the same thing with my own experience, having set up the cryotherapy program there in our ambulatory center. Now, the cryo is what I do, which is outpatient procedure. But, it's once I'm finished with the procedure and the patient, which takes me about an hour, and the patients go to the recovery room. Those nurses are just fantastic out there at that Zeckendorf ambulatory center. Because I've done about 100, I haven't done the thousands that you have at Winthrop, but I've only been there about a year. I've done about 150 over the past year, and they're very caring. They know what to do, just to take care of the patient and, get them out of the recovery room and then back home. And the patient satisfaction is extremely high, as is the nurses in the hospital that take care of the patients that undergo robotic surgery. We have just a few moments, John, so let's get to the phones real quick again. Maybe we'll hear from Joseph. I know you've been hanging on a bit. Dr. Haas has been going on and on. So, Joseph, how can we help you this morning?
Yes, good morning. Thank you for taking my call.
Sure.
I've had 2 biopsies already, and I've been diagnosed with low-grade cancer, and I'm on watchful waiting. And when I went for my regular physical, my PSA, I know that's not, when you go for a physical and take a blood test, it's not just, for your PSA, it goes for all the different things in your body, but it was like 3.5. And then my last one, when I went to the Columbia Presbyterian, it was 4.7. So
that's why you shouldn't go to Columbia.
No,
Ouch. No, I'm kidding.
My question
yeah.
is, and since I've been diagnosed, and I've talked to 10 different people, they had the seeds, they had the robotic removal, they had the radiation, they had everything.
Yeah.
So I'm not afraid to talk about what's going on. But I'm getting all my emails and everything from John Hopkins, and I'm telling you one thing, seriously. My head is up in the air about everything. PSA doesn't matter. They did this and there's that and there's this and.
Well, let me hold on a second. Calm down a second now. First of all, PSA once you're diagnosed, I think does matter. Okay, there's controversy about whether or not it should be used routinely in the screening population. Just a guy walking out there on Broadway, whether PSA is helpful. But in your particular case, since you've been diagnosed, I disagree, and I think that it is helpful. And I think one thing that I would do, Joseph, because you're in active surveillance and you're just kind of watching it, is I would come out to our hospital and I would get an MRI. You need a 3.0 T MRI to see what's going on in your prostate to make sure that there's no other disease in the prostate and your prostate capsule is okay. And also to talk to us, if you want to maintain and stay on active surveillance, to talk to us about our holistic and integrative program that we have to change your diet, add supplements, and watch it. Johnny, what do you think here?
Yeah, no, I agree. Once you're diagnosed, the PSA is incredibly important, and we can argue the value of screening, and Aaron and I have taken the position that there is still huge value in screening. But once you're diagnosed, the PSA is probably the most accurate way, or one of the more accurate ways to follow your cancer. And you're right. A lot of patients have their heads up in the air, to quote you. But you're not going to make a wrong decision. Your job as an informed patient is to look at the different options. Maybe find someone that's gone through the treatments and talk to them. And you're not going to make a wrong decision, whatever that may be. And that may be going on an active holistic surveillance program, maybe going on a surgical program, a radiation program. So, the advice I give all my patients: do your homework, and don't just talk to doctors. Ask if the doctors have a list of patients that have gone through their treatment. You talk to Mr. Smith that had robotic surgery last year. Talk to Mr. James that had a cryoablation with Dr. Katz. Talk to Mr. Jones with Dr. Haas.
That's a very good advice. Joseph, what was your Gleason score there? Was it do you know?
It was 6.
It was a 6. Did you have a lot of cores that were positive, or just one or two?
Out of 14 samples, it was 3.
3. All right. Well, it sounds. Do you know what the volume of the cancer was in each of those, or you don't know? Was it?
Can I ask you one question? Because I just got my report back, and I asked the doctor at Columbia.
Real quick, you got a few seconds. Go ahead.
Send me the report. And free prostate. Could you explain that free prostate? What is that?
You mean the free PSA?
Yes.
Yeah. Okay. Well, the free PSA, and thanks for your phone call, Joseph. Sorry we don't have more time. We want to get more time. A lot of patients say, "Why can't you get more time on WABC?" Well, it comes down to funding. And we could probably do this show here, Dr. Haas, right, John? Probably the next 3 hours, and we get phone calls as the phone board is lit up. But,
without a doubt.
The free PSA is an indicator of whether or not if your PSA is elevated, if it's elevated more from a benign condition than from a cancer standpoint. And the lower the free PSA, the higher the chance of cancer. And it's used basically as a screening tool to help to determine if you need a biopsy. And I use that in my practice at Winthrop, the free PSA. I also use the cancer gene, the PCA3 test. I use that quite a bit, as well as the transrectal ultrasound, to determine who needs and who does not need a biopsy. Jonathan, you've been a great guest. You can check him out at winthrop.org. Any last moment in this? We got only... Well, they're playing the music, so...
It's good music.
It is good music.
Thank you for having me on again.
All right, well, tune in next week. You were a terrific guest, as always. That's Dr. Jonathan Haas. He runs a CyberKnife program. Fantastic guy, fantastic program. Check him out on the web. And don't forget, come to our seminar, Father's Day weekend. That's menshealthseminar.com. Menshealthseminar.com. I will see you next week. Have a wonderful week. It's going to warm up real nice. This is Dr. Aaron Katz.